Good afternoon, everyone. I'm a cardiac surgeon, and yes, I crack people's chests open every day. Something very fascinating to me about how someone could trust me to crack open their chest and work on their heart and know that everything was going to be okay after I've only met them several minutes before. It is a responsibility and a privilege and an honor to be able to earn someone's trust in the snap of your fingers. And I take this responsibility very seriously because of one particular patient that I had very early on in my career as I was a young cardiac surgeon. The first time I ever had to do emergency surgery on someone in the middle of the night, it was a little lady named Mary. And I would like to share my story of my interaction with Mary with you to help you to understand how I feel about this responsibility. Around 2 o'clock in the morning, one morning, I was called by an emergency room doctor to come to see a patient who was 80 years old, a little old lady who had an aortic dissection. An aortic dissection is a life-threatening emergency where the blood, every time your heart ejects the blood to the rest of your body, it goes in between the layers of the blood vessel and shears a new way, and sometimes this can rupture into the chest and the patients will eventually die. Indeed, most of these patients don't even make it to the hospital. But Miss Mary was fortunate enough to call the ambulance when she did and get to the hospital and presented to the emergency department with this problem. And me, having just finished my residency training and having read all the textbooks and passed my boards, I felt like I was ready for this opportunity to be able to help Mary. So on the way to the hospital, I was going through the myriad hundreds of steps that it takes to accomplish this operation in my head over and over and over again because I felt like I was her only hope. And so I get to the emergency room and I walk into her room and she's obviously in quite a bit of discomfort. And she listens to what I have to say. I told her about all the potential complications and what could happen, what might happen, how her recovery was going to be. I told her every single thing that I had learned to tell her. And at the end of that conversation, she pulled me close in her weak little voice. She told me that it was going to be okay because I had kind eyes. And so I went about preparing for the surgery and making sure that the dozen or so people that were getting everything ready were on their job so that we can be successful in this endeavor. And the perfusionist was there and ready to go with the heart-lung machine. And I step up to the operating sink to scrub my hands. And it occurred to me that she said that she trusted me with this responsibility because I had kind eyes, never having met me before in my life. And even though she was scared out of her wits and nervous about this potentially life-threatening problem that she has, she wanted to give me the confidence to be excellent to save her life. And so I was thinking about that as I was preparing to scrub into the operating room. And of course, I was thinking about all the other 1,000 things that I had to do as well, but I kept coming back to this particular statement because it resonated to me that I had spent 8 years in college and medical school and 9 years training to be a cardiac surgeon, and I knew every technical thing there was to do, but it did not prepare me at all for seeing that little lady, 80 years old, in her bed, scared that she was going to lose her life. And the gravity of that situation really kind of resonated with me while I was washing my hands. So we get into the operating room, and I step up to the table, and everybody has prepared the surgical field so that all I see is a 6 square inch area. And we open Miss Mary's chest. And this operation to repair this problem is the most maximally invasive operation that you can imagine. We have to open the chest. We have to put the patient on the heart-lung machine. We have to wrap the head in blankets and towels and then put ice on the head. We have to cool the patient down to about 18 degrees centigrade because it slows the metabolism. And we want to have time to be able to accomplish the operation. Because in this operation, you actually have to stop the heart, and the heart slows down as it gets colder. The metabolism slows down. Everything slows down to a crawl. And eventually, the heart stops. And the patient is actually laying on the table without a heartbeat and without any blood circulating through their body. They're effectively dead. And even though stopping someone's heart and stopping their circulation would be a remarkable thing in any situation, it's especially remarkable now because we have to do this in order to be able to accomplish the operation. We have to evacuate the blood from the heart and from the big blood vessels around the heart to be able to sew the graft to this place very meticulously, because one needle throw in the wrong place could mean torrential bleeding and certainly could lead to the patient's demise. So we go about evacuating the blood, fixing the dissection, which looks like a bomb has gone off inside someone's chest. It's really hard to tell one thing from the other. It takes about 20 to 30 minutes. And eventually we ask the perfusionist to rewarm the patient, and we wait, because rewarming takes a lot longer than it takes to cool the patient. And we wait, and eventually we have a heartbeat, and then another heartbeat, and she's back. It's a very remarkable thing, and I think while we're waiting and while we're rewarming the patient, it goes through my mind over and over again how she trusted me to crack open her chest and hold her heart in my hands and fix it, because I had kind eyes. So this relationship has been really something that I have considered just about every time I go into surgery and talk to patients, because I think that it is the most important relationship that they don't teach you about in medical school. And now we have come to an era where we can perform maximally invasive heart surgery. We can take people and spend hours and hours and hours in the operating room and fix them, and they will do very well for a long time afterwards. It is a remarkable time now to be a cardiac surgeon, because even though we can do these maximally invasive things, we have so many things now that we can do minimally invasively. Things that we can do sometimes percutaneously, where patients can go home the same day or the very next day. So I've had to think about this relationship between the patients and their doctors over the years in very different ways, because now we have access to so much technology that makes it so wonderful to be able to treat people, to give them the kind of lifestyle that they have expectations of receiving, because they watch the Today Show and all of these other shows that show them how you can have such a great recovery, that it is a special time for us, and certainly a special time in Baton Rouge because of the fact that we have more access to these kinds of transformative technologies now than ever before. Within the last 6 months in Baton Rouge, we have grown our portfolio of minimally invasive procedures fourfold within 6 months. And we've had access to these technologies for the last 7 or 8 years. It all started for us at Baton Rouge General about 7 years ago, and I give a photo credit to Edgardo for this one. We performed the first minimal access mitral valve repair surgery in this area. We were able to do open heart surgery on a patient with a closed chest through a keyhole. Quite remarkable, and certainly a testament to the generous gift from the foundation, which allowed us to be able to have this hybrid operating room to be able to perform all of these operations. We can now perform surgery for aortic stenosis, which is a blockage in the aortic valve, which is that main blood vessel that comes from your heart and carries blood to the rest of your body. Usually, you pump all of that blood, about a gallon of blood every minute, through a hole about the size of a quarter. In aortic stenosis, that hole is about the size of a pea. So you can imagine how much harder the heart has to work to get the same amount of blood through that little pea-sized hole as it used to get through the quarter-sized hole. Used to be a time 7 or 8 years ago when this was a maximally invasive operation. We had to open people's chests and take out the old valve and put in a new valve. And now, every week, we perform this operation where we go through the groin and put a stent inside the aortic valve and give people a new valve. Most of the time, they go home the very next day, able to resume their normal level of physical activity. It's an amazing time for cardiac surgery right now. We can repair holes in people's hearts with a plug. It takes about 20 minutes. We can pinch valves together on the inside through percutaneous techniques and obviate them from having a process that we call mitral regurgitation and literally allow them to be able to catch their breath again without having maximally invasive surgery. And this is remarkable for me in light of the story that I told at the beginning about Mary, because of the fact that I've spent years and years learning all of these techniques. And when you develop a skill set that is remarkable, your passion is to want to use it for everybody. But we have to have some restraint when we try to match patients to the technology, because I think that it's really important to match the technology to the patient and to give patients an understanding of the breadth of technology that is available to them. And sometimes this is conventional surgery when patients come to my office with reams of internet data saying that this is what I need because this is what I have. And so that is where I think that trust level between the doctor and the patient actually becomes even more important in this day and age. And it has changed from having to trust someone to crack open their chest to having to trust that someone is going to represent to you an accurate representation of your risk for having one type of therapy or the other, whether it be minimally invasive or maximally invasive. You have to have someone that can describe to you what's going to happen, what the chances are of these things happening or these complications happening. And it is really incumbent upon the physicians to be able to relate this to the patients in a way that they can understand, because we have all of these bells and whistles and new technology. But really, it's not about the technology. Sure, it's important to have good outcomes and to be able to say that you're the first to do this or the first to do that, but it really is about a relationship that the doctor has with the patient. If you can represent to them what their expectation of success is with each individual type of therapy, then you can help them to cope with the very real and human emotions of anxiety and fear and apprehension that go along with this life-changing event. And it's a life-changing event for the patient, certainly, but obviously for the doctor as well. And you have to remember, at the end of the day, it's about a patient and a doctor. Thank you very much.